Hi, so today we are going to talk about cerebral palsy. We are going to talk about the definition, the types, the different etiologies, risk factors, clinical features, investigations, and finally the treatment of cerebral palsy. And at the very end of this video, we are also going to discuss some pretty interesting MCQs, so please stick till the end of this video. Now, let's talk about the definition of cerebral palsy. In the definition of cerebral palsy, one thing that is really important to understand is that cerebral palsy is a non-progressive disease. It is non-progressive disease in the sense that it is not a disease like Parkinson's or Alzheimer's that is progressive. It is non-progressive disease. The amount of injury or damage to the brain that has been done during the early childhood, remains same throughout the life. And once that damaged part of the brain has been gone, it does not get further more damage. So the amount of damage remains the same, and thus the amount of clinical features of a cerebral palsy also remains the same. It is non-progressive, it does not grow. And because of this non-progressive insult to the brain, there is hampering or loss of neuromotor functions. So function that is almost always associated with the motor functions. And besides most of the motor functions, there can be some other functions also, like sometimes it can also be associated with abnormal body movement like seizure activities. It can be associated with mental retardations, but predominantly cerebral palsy is a disease of neuromotor functions. Okay, now why does cerebral palsy occur? Cerebral palsy occurs because of an injury or insult to a growing brain. So while the brain is in its initial growth phase, if injury occurs to any part of the brain during this growth phase, then there is development of cerebral palsy. So brain grows up to 3 years of age. So if injury of brain occurs into the first 3 years of age or before the birth, so during the late fetal life, during the delivery, as well as in postnatal age up to 3 years, if there is any kind of injury to the brain and there is damage to the certain part of the brain, so this leads to a non-progressive neuromotor type of disease, ultimately called cerebral palsy. Now, this insult to the growing brain can occur at any period. It can occur in late fetal period, also known as prenatal. It can occur during delivery. The example of this would be birth trauma. All right. Okay. And it can also occur in the postnatal, but up to 3 years of age or less. Right. So postnatal trauma can include directly head trauma. It can include CNS infections, or it can include vascular injuries. Right. Okay. So finally, the definition would be cerebral palsy is a non-progressive neuromotor type of disease caused due to insult to the growing brain of a children less than 3 years of age. So that is the definition of cerebral palsy. Now, cerebral palsy can be classified clinically into various types depending upon which part of brain was injured. So if there was injury to the cortex, then you will have a disease called spastic cerebral palsy. If there is damage to the deeper part of the cortex, that is, if there is damage to the basal ganglia, which is associated with coordinating the fine coordination of the motor movement, then you will have dyskinetic type of cerebral palsy. And finally, if you have damage to the forebrain and damage to the cerebellum, then you have ataxic type of cerebral palsy. So let me explain this once again. So this is the brain taken in the coronal section. Okay, now if there is damage to the cortex part, so if there is damage to this part, if this cortex is damaged, then remember that all the pyramidal fibers for control of the motor control of the different muscles radiate in this form as corona radiata grows downward, and these are first order neurons, and then synapse on the second order neurons, and second order neuron come back and supply a muscle. So if there is damage to this first order neuron, that's it, there is damage to this cortex, then you will have upper motor neuron type of palsy, because this first order neuron will not send inhibitory impulse to the second order neuron, and thus the second order neuron will be unregulated and it will increase in its firing rate, and hence the muscle will start contracting too much, and the muscle will goes into a spastic type of paralysis. And hence, if anyone says the cerebral palsy is a spastic type of cerebral palsy, then think the damage is in the cerebral cortex, right? Okay. Now, if the damage is in the deeper nuclei, the nuclei which are present in this part of the brain, like as shown here. So damage to the thalamus, putamen, globus pallidus. So indirectly I'm saying that if there is any type of damage to the basal ganglia, then basal ganglia is typically associated with the fine tuning of the motor activity. Hence you will have disease like Parkinson's, okay. So it is shown here. So if you have any kind of damage to the basal ganglia, this is thalamus, putamen, globus pallidus externus, internus, subthalamic nuclei, and caudate nucleus. So if this part of the brain undergoes injury because of various causes, there can be various causes of injury to this part of the brain. It can be neonatal jaundice, it can be some other cause, it can be status mammarata, which I will talk later on. But if somehow or anyhow there is damage to this part of the brain, then it will manifest as Parkinson's-like disease. Parkinson's-like disease in the sense that the features will be chorea, athetosis, and dystonia. And this type of cerebral palsy is known as dyskinetic cerebral palsy. Now, dyskinetic cerebral palsy occurs because there is injury to basal ganglia, right? Okay. Now, why would there be injury to basal ganglia? So one disease I think almost all of us know is that kernicterus. In kernicterus, there is unconjugated hyperbilirubinemia, and this unconjugated hyperbilirubinemia ultimately goes to the basal ganglia and stains the basal ganglia, and there is long-term irreversible damage to the basal ganglia, and the patient typically presents with chorioathetoid type of cerebral palsy, also known as dyskinetic cerebral palsy. Besides that, if a term infant, that's a fully term infant, more than 37 weeks of gestation, if the term infant undergoes perinatal asphyxia or hypoxic ischemic encephalopathy, then there is a good chance that there is going to be some kind of damage to the basal ganglia. And this damage, when you do a CT MRI, will have a typical marbled appearance. And hence this type of damage is known as status marmorata. Right? Okay. Status marmorata. So the second cause of dyskinetic type of cerebral palsy would be status marmorata. Okay. And finally, sometimes there can be disease like inborn error of metabolism. So there is excessive accumulation of some kind of metabolites. There's those metabolites, just like unconjugated hyperbilirubinemia or unconjugated bilirubin, goes to this basal ganglia and gets deposited there, and ultimately leads to irreversible damage to the basal ganglia. So inborn error of metabolism is also an example of chorioathetoid type of cerebral palsy. Okay. Finally, ataxic cerebral palsy, as we know that there can be the damage to the cerebellum. If you have a damage to cerebellum, then you can have ataxic type of cerebral palsy. So if you have damage to the cerebellum, you will have ataxia. You will have the child typically have a wide stanced gait, and the child will have intense tremor. It is quite easy thing to understand that ataxic type of cerebral palsy occurs because of injury to the cerebellum. But one typical important thing, and often asked in MCQ, is that most common site of injury in brain in ataxic type of cerebral palsy is forebrain and not cerebellum. Most commonly associated site of brain injury, as done in radiological studies, shows that there is more injury to the forebrain than cerebellum, and it's a pretty difficult thing to explain why forebrain damage would cause ataxia. But immediately followed by forebrain, there is involvement of cerebellum in up to 20-25% of the cases of the ataxic type of cerebral palsy. So we have discussed the ataxic cerebral palsy, we discussed dyskinetic type of cerebral palsy. Dyskinetic type of cerebral palsy typically presents with chorea, athetosis, dystonia. Hence it is also known as chorioathetoid cerebral palsy. Right? Okay. And I already told you that if there is damage to the cerebral cortex, then it presents as a spastic type of disease. Now, depending upon which part of cerebral cortex is damaged, the spastic cerebral palsy can also be of three types: spastic diplasic, spastic quadriplegic, spastic hemiplegic. Spastic diplasic means there is a spastic, there is upper motor neuron type lesion in two legs, let's say both the legs. Where spastic quadriplegic, there is upper motor neuron type lesion in all four limbs. Right? Plus there can be also be involvement of trunk. Right? And finally, spastic hemiplegic is there is a upper motor neuron type lesion in upper limb as well as lower limb of only one side. Right? Okay. So spastic diplegic, quadriplegic, and hemiplegic. Now, spastic diplegic is almost always associated with prematurity. It is almost always associated with prematurity. So prematurity or low birth weight infant who was born less than 37 weeks of gestation or whose birth weight was less than 2.5 kgs. These child almost always have periventricular leukomalacia. Periventricular leukomalacia can be explained from this figure. You can see here the blood supply to the part of white matter immediately outside the ventricle or immediately adjacent to the ventricle. Let's say this periventricular area which normally consists of white matter has a little bit of precarious blood supply. The blood supply to this area is precarious and not much fully developed, and the condition is more exaggerated in case of preterm baby. The preterm baby have more precarious blood supply, and hence preterm baby have increased risk of undergoing damage or injury to this white matter because the blood supply is very precarious, and ultimately this white matter does not develop properly and there is leukomalacia. Malacia means undeveloped or hypoplastic, and leuko means white matter. So if you have periventricular leukomalacia because the child was born less than 34 weeks of gestation and the child weighs less than 2.5 kgs, then you will going to have periventricular leukomalacia, and this will lead to damage to this part of the cortex, the part of the cortex which is just adjacent to the ventricle. So if this is the ventricle, then the part of the cortex just adjacent to the ventricle on both the sides gets damaged. So this part of cortex on both of the side gets damaged. And now we know that the medialmost part of motor homunculus, this medialmost part controls the lower limb, and hence the baby will develop upper motor neuron type of palsy in the paralysis in the lower limb and both the lower limb bilaterally, and hence this is called spastic diplegic. There is involvement of both the legs and legs only and not upper arm. Some kind of weakness in the upper arm may also be present, but whatever be it, the more weakness will be present in the lower legs. Okay, now spastic quadriplegic occurs in those children who were born at term, so more than 37 weeks of gestation, and who underwent perinatal asphyxia or hypoxic ischemic encephalopathy. Hypoxic ischemic encephalopathy or perinatal asphyxia in the sense that after birth their brain suffered a global ischemia. All the blood vessels in their brain developed ischemia. This is blood supply from all the blood vessels decreased together, especially in those children who were born at term, so more than 37 weeks of gestation. Now you can see that anterior cerebral artery is present here, and it supplies and gives branches and supplies blood to the part of the brain in this way. Middle cerebral artery arises from here, comes out and gives and blood supplies to the brain in this way, and posterior cerebral artery is present in somewhere around in this pattern and supplies blood in this way. Now you can note that there are two areas, this area and this area, and these are called watershed areas. Watershed areas in the sense that they have very high blood supply because they are supplied by the end arteries of the two branches. So anterior cerebral artery and middle cerebral artery, both of them supplies this area, this triangular area, whereas this triangular area is supplied by middle cerebral artery and posterior cerebral artery, and this is called watershed area. Now watershed area may have its advantage when the blood supply is good. Let's say it is supplied by both middle and anterior cerebral artery, so that if any of the artery gets damaged, the blood supply in that part will be maintained. But if we talk about perinatal asphyxia or hypoxic ischemic encephalopathy, what happens is that there is global ischemia. So blood supply from anterior cerebral artery, middle cerebral artery and posterior cerebral artery, blood supply from all the three arteries decreases. Now this watershed area being distant, most away from anterior cerebral artery and middle cerebral artery as well, and this watershed area being distant the most away from the posterior cerebral artery and middle cerebral artery as well, undergoes the most damage if you have global ischemia or hypoxia. So this watershed area, which was once favorable because had most blood supply, now becomes disadvantaged, especially if you have global hypoxia and ischemia, which occurs in a term infants, which typically occurs only in term infants more than 37 weeks of gestation, if they suffer from any kind of anything that trigger perinatal asphyxia or hypoxemic encephalopathy. And this damage to the watershed areas, especially these two areas, ultimately leads to spastic quadriplegic type of cerebral palsy. Quadriplegic because damage to this part of area ultimately leads to upper motor neuron type of lesion in lower limbs, right? Whereas damage to this part of the area, this area ultimately leads to upper motor neuron type of lesion in upper limbs, right? So there is involvement of both upper and lower limb, and in between them there is also some part of trunk, so there can also be some involvement of trunk. So spastic quadriplegic, which typically occurs in term infant more than 37 weeks of gestation who undergoes perinatal asphyxia or hypoxemic encephalopathy, is the most severe form of cerebral palsy because there is involvement of all four limbs. Not only that, there is also involvement of trunk. So this may also present with scoliosis, right? Not only that, this disease causes a global damage to the larger part of the brain parenchyma, and hence they are at the increased risk of seizure, neonatal seizure or refractory seizures. They are also at the increased risk of mental retardation. They are also at the increased risk of bulbar palsies. Bulbar palsy means the palsies of the cranial nerve. So they are at the risk of developing dysarthria, inability to speech or slurring of the speech, as well as dysphagia, inability to swallow or eat, as well as sometimes involvement of the oculomotor nerve or cranial nerve 3, right? Okay, so this spastic quadriplegic, it can be formed in form of MCQ, that it is the most severe form of cerebral palsy. By the way, what is the most common type of cerebral palsy? The answer would be spastic. So spastic cerebral palsy is the most common type of cerebral palsy, and within the spastic, it is spastic diplegic, which is the most common type of cerebral palsy. Most severe cerebral palsy is spastic quadriplegic, right? Okay, why is it most severe? Because there is involvement of seizure, there is mental retardation, there is also bulbar palsies, which ultimately leads to dysarthria, dysphagia, as well as oculomotor nerve palsies, right? Okay, now finally there can also you can have injury to the brain, but that injury is associated only in the one side. It is localized only to the one side of the brain, as you can see in this picture, right? Sometimes what happens is that you can have periventricular leukomalacia, but rarely it is only unilateral periventricular leukomalacia. Only in the one side of the white matter there is damage, and such patients will have hemiplegic. So spastic hemiplegic type of cerebral palsy, there is only one side involvement of both upper and lower limb. But more than this point, the important thing is vascular. Sometimes children can have vascular hemorrhage or stroke only in the one side, which leads to damage to the cerebral cortex, which controls both the lower and upper limb of the same side, and ultimately leads to a spastic hemiplegic type of cerebral palsy. Sometimes you can have infection like CMV and toxoplasma, ultimately leads to space occupying lesions, and space occupying lesions present only in the one side, and it causes compression of different brain parenchyma of that side, and ultimately to spastic hemiplegic type of cerebral palsy. Sometimes cerebral malformation. So one example, a very important example, is post-hemorrhagic porencephaly. What happens that sometimes you can imagine that there is a vascular event or there is some kind of hemorrhage, and due to hemorrhage there is accumulation of large amount of clot, and the brain parenchyma surrounding the clots gets compressed. Now what happens that during the due course of the time, that brain parenchyma which was compressed by the clot ultimately gets reabsorbed or does not develop properly, which ultimately leads to formation of a cavity or cavitating lesion within the brain, which does not consist of any brain parenchyma, and this is called post-hemorrhagic unilateral porencephaly. And this post-hemorrhagic unilateral porencephaly is another cause for spastic hemiplegic type of cerebral palsy, right? So spastic hemiplegic type of cerebral palsy's etiology include unilateral periventricular leukomalacia, vascular hemorrhage or stroke, CNS infection like CMV and toxoplasma, as well as cerebral malformation after hemorrhage, which is called post-hemorrhagic porencephaly. Now, if we talk about the severity, we know that it is the most severe form is the spastic quadriplegic. It is associated with seizure as well as mental retardation. Please note a fact that spastic diplegic is not at all associated with seizure, or it is not at all associated with mental retardation. Whereas spastic hemiplegic is in between the spastic quadriplegic and diplegic. That is to say, there can be some cases with seizures and there can be some cases with mental retardations. So up to 33% of the cases of spastic hemiplegic cerebral palsy have seizures, and up to 25% also have mental retardation, right? One more thing is that some authors also classify cerebral palsy in additional two classes. One being atonic type of cerebral palsy, and finally another is mixed type of cerebral palsy. Now let's talk about atonic cerebral palsy. Now, one reason of me not including atonic type of cerebral palsy in this classification is that atonic cerebral palsy has become a thing of a past. So previously there used to be a classification that include atonic type of cerebral palsy, but now it has been discarded and many authors do not use it. Current authors have stopped believing that atonic cerebral palsy is a separate entity. So most of the time what happens is that child initially presents as a feature of atonic cerebral palsy. That's atonic means all the muscles are completely flaccid. There is no any spasm in any muscles. So there is complete flaccidity. Now this flaccidity is then followed by any three type of disease. So from this acute phase of flaccidity or complete flaccid paralysis, the child can go into spastic, or can go into choreoathetotic type of cerebral palsy, or finally can go into ataxic type of cerebral palsy. So instead of atonic cerebral palsy being considered as a separate entity, it is considered as a pre-pathogenic stage of spastic, choreoathetoid or ataxic type of cerebral palsy. And but yet rarely there are some rare cases in which atonic type of cerebral palsy persist as an atonic, and throughout the life these children remain completely atonic, do not develop either spastic or choreoathetoid or ataxic type of cerebral palsy. But this being very rare, most of the authors do not classify atonic type of cerebral palsy on its separate entity. And finally there is mixed type of cerebral palsy. Mixed type of cerebral palsy is mixed manifestation of multiple type of cerebral palsy. So there can be spastic quadriplegic type of cerebral palsy with ataxic. In fact, this combination is the most common combination of mixed type of cerebral palsy. There is spastic quadriplegic with ataxic type of cerebral palsy. Now that we have covered all the classifications of cerebral palsy, let's go into the clinical features of cerebral palsy. Now, clinical features will depend upon the classification. If there is spastic cerebral palsy, there is going to be spasm in the limbs. If there is dyskinetic cerebral palsy, the child is going to have some kind of dyskinetic features like chorea, acetosis, dystonia. Or if it is ataxic, then child is going to have intense and tremor, wide stanced gait. Right? Okay. But still, let's see the clinical features. So one way to learn or study clinical features of cerebral palsy is to classify as general features and specific features. So general features are those features which are present in all type of cerebral palsies. So all type of cerebral palsies are going to have all these four features. Almost all will have some degree of these four general features, right? Okay. So one is delayed milestones. So children with cerebral palsy will have delayed milestones. So normally a children should be able to sit by 6 months of age, but in cerebral palsy this will be delayed. Or the children should be able to walk by 12 to 15 months of age, but in cerebral palsy it is delayed. Or the children should be able to stand without support by 12 months of age, but in cerebral palsy this is delayed. So there is ultimately delay of motor milestones. So there is delay in achievement of milestones. And besides that, there is abnormal persistence of primitive reflexes. So primitive reflexes like Babinski reflex. So Babinski reflex is persistently positive, that is say upgoing and fanning type of Babinski reflex is present for more than 1 year of age, and it is abnormal. So it is abnormal persistence of primitive reflex. Besides that, one very specific indicator of cerebral palsy is abnormal persistence of Morose reflex. Typically Morose reflex resolves or disappears by 3 to 6 months of age, but abnormal persistence of Morose reflex beyond 6 months is indicator of possible cerebral palsy. Now besides that, cerebral palsy can also have features of seizure and mental retardation, but these two features, seizure and mental retardation, is generally absent in spastic diplegic type of cerebral palsy, and it is present in variable frequency in other three classification of cerebral palsy. Now as a whole, if I talk about cerebral palsy, like 25% of the patient are going to have no mental retardation, they are going to be normal. In the rest of the 25%, there will be borderline intelligence, whereas in 50% of the patient with cerebral palsy will be mentally retarded. So if a question comes, the percentage of mental retardation in cerebral palsy, the answer would be 50%. So 50% of the patient of cerebral palsy are mentally retarded. Okay, and which type of cerebral palsy is most strongly associated with mental retardation? The answer would be the most severe form of cerebral palsy itself, that is a spastic quadriplegic type of cerebral palsy, which I have stated earlier. Okay, so these four are the general features present in almost all types of cerebral palsy except for this one. Okay, now let's talk about specific clinical features of cerebral palsy. Let's talk about spastic type of cerebral palsy, this being most common. That's why we were going to discuss this first. Now within spastic, we are going to talk about spastic diplegic. So I have already told you that in spastic diplegic, there is damage to the cerebral cortex of the anterior cerebral artery distribution. So that is to say, there is damage to that part of homunculus which supply innervation to the lower limb, and hence you are going to have an upper motor neuron type of lesion in the both legs, that's the lower limbs. So because there is upper motor type of neuron, there is increase in the tone, and there is a spastic type of rigidity. There is spastic rigidity of the lower legs, and because of upper motor neuron lesion, there is increased tone, there is increased deep tendon reflexes, and because of the same fact that there is upper motor neuron lesion, the Babinski reflex is persistently positive beyond 1 year of age. And one thing to note is that in lower limb, two muscles, especially two muscles, are at they have more pronounced type of spasms, especially the medial compartment muscles of the thigh, that is say adductor muscles. The adductor muscles, one will have excessive spasms, and secondly the muscles of the posterior compartment of the leg. So due to this, there is active spasm of the Achilles tendon, and over a long period of time there is also shortening of the Achilles tendon, right? Shortening of the Achilles tendon. So these two muscle compartments, the adductor muscle compartment and posterior compartment of the lower leg, which ultimately leads to the Achilles muscle or Achilles tendon, gets spasmed as well as gets shortened. So this leads to two type of phenomena. Number one phenomenon is that these children with spastic diplegic type of cerebral palsy cannot use their legs because they are paralyzed. So while they crawl only using their upper limb and their trunk. So they can only use their trunk and upper limb while crawling, and this type of crawling is pretty common and famous in commandos, and hence it is called commando crawl. After that, they will have difficulty walking because they have spastic diplegic type of cerebral palsy, and because of spasm of this medial compartment of muscle, adductor muscles, there is abnormal adduction of both limbs. So right limb is adducted towards left and left limb is adducted towards right. Ultimately there is scissoring of the two legs. The two legs cross each other, and this is called scissoring. And if this type of child walks, the gait will be scissoring gait. Right? Okay, this is called scissoring gait in cerebral palsy. So question can be, scissoring gait in cerebral palsy is present in which type of cerebral palsy? The answer is spastic diplegic type of cerebral palsy is most commonly associated with scissoring gait. Right? Now finally, I told you about how the muscles of the posterior compartment of the leg also get shortened and spasmed, due to which this Achilles tendon gets shortened or spasmed. And due to this shortening of the Achilles tendon, the heel is lifted upward and the leg goes into plantar flexion. And due to this plantar flexion, the child has to walk with tiptoe, and this is called tiptoe walking. Right? So there is Achilles spasm or shortening, and ultimately this deformity looks like a leg or foot of a horse, and this is called equinus deformity. And this type of walking is called tiptoe walking. Okay, So once again, in spastic diplegic type of cerebral palsy, there is upper motor neuron lesion of both legs. There is increase in the tone. There is spastic rigidity. There is increase in deep tendon reflexes. Bobinski sign is upgoing and fanning, and there is initially commando crawl. There is delayed walking, and even if the child walks, he will have scissoring type of gait because of adductor spasm, and even because of Achilles tendon shortening, he will have equinus deformity, as well as due to this equinus deformity, if he walks, he will walk in a tiptoe manner. Right? Okay, now let's talk about spastic quadriplegic. We know that spastic quadriplegic is the most severe form of cerebral palsy. You can see here that there is involvement or injury there is involvement of both upper limb as well as lower limb, and that is the reason why it is most severe. Not only that, it is most severe because it is associated with seizure, it is associated with mental retardation, it is associated with bulbar palsies like dysarthria, dysphagia, right, as well as there is involvement of oculomotor nerve, right? Okay, so in lower limb, the manifestation of spastic quadriplegic type of cerebral palsy is very similar to that of the spastic diplegic. So in lower limb, there will not be much difference. What additional feature will be there in spastic quadriplegic? Yes, there will be involvement of upper limb also, and due to this involvement of the upper limb, he will have the child will have a special type of deformity which is called cortical thumb. Cortical thumb means that the children, when they are born, they have this thumb which is flexed and adducted, in the sense that they are closer to the plane of the hand. They are opposed towards the plane of the hand, and it is also flexed. This flexion and adduction of the thumb is called cortical thumb. It is present in almost all child, but it generally resolves normally, but in cerebral palsy it is abnormally persistent, and this type of thumb is called cortical thumb. So in upper limb there is one manifestation which is called cortical thumb, as well as I told you there is a most severe. Why? Because it is involvement of bulbar involvement. So this bulbar involvement is associated with dysarthria and dysphagia, difficult to swallow because of spasm or weakness of the pharyngeal muscles, right? Okay, and it is also associated with seizure, and it is also associated with mental retardation. Okay, right. So MCQ is that it is the most severe form of cerebral palsy. Which is the most severe form of cerebral palsy? That is spastic quadriplegic. Okay, finally there is the spastic hemiplegic type of cerebral palsy. There is upper motor neuron type of lesion, in both upper as well as lower limb, but it is only unilateral, only in the one side. So because it is unilateral, the child is going to develop early hand preference. So normally we develop hand preference, let's say we become either right-handed or left-handed by 3 years of age. It is by 3 years of age that we become either right-handed or left-handed. But if you observe a child which is right-handed and left-handed at 1 year of age or less than 1 year of age, then it is called an early hand preference or early handedness, and it is one of the indicator of cerebral palsy. Why? Because obviously because of the fact that that side of the body which underwent hemiplegia, the child cannot use that side, and hence only the remaining or sparing side is used by the child, ultimately leads to an early hand preference. And because of hemiplegia, the child will have difficulty walking, and there will be delay in the walking. Normally walking should begin like 12 to 15 months, but this child will start walking only at 18 to 20 months. But even if this child walks, then he cannot use one leg. His one leg cannot flex. He cannot flex knee as well as cannot flex ankle joint, and that is the reason why it remains as a single unbendable leg, and hence when he walks he will have to shift all his weight on the another leg or healthy leg, and then move this leg in circumduction fashion. It is shown in this figure that normal leg is advanced normally, whereas the other leg which has underwent spastic hemiplegia is swinged across, and this is known as circumductive gait. And circumductive gait is important in spastic hemiplegic type of cerebral palsy. So once again, circumductive gait, early hand preference indicates spastic hemiplegic type of cerebral palsy. Now, spastic hemiplegic type of cerebral palsy also have some associated features like seizure and like mental retardation, but it is in between spastic diplegic and spastic quadriplegic. So it is less than spastic quadriplegic. So up to 33% of the cases of spastic hemiplegic will have seizure. Up to 25% of the cases of spastic hemiplegic will have mental retardation. Okay, now finally we have still two types of cerebral palsy left. What is dyskinetic? We know that in dyskinetic cerebral palsy there is damage to the basal ganglia. If there is damage to the basal ganglia, it will have Parkinson's type of injury, and it will ultimately lead to chorea, athetosis, as well as dystonia. Even dyskinetic type of cerebral palsy is associated with dysarthria and dysphagia. Even choreoathetoid type of cerebral palsy is associated with seizure and mental retardation, but it is not that common. Often it is absent. Involvement of seizure and mental retardation is not that common, and it is often absent, but in some cases it may be present. So remember, spastic diplegic is the most safest form of the best prognosis, because there is no seizure, no mental retardation, which is followed by choreoathetoid type of cerebral palsy. There is only some cases have seizure and some cases have mental retardation, and after that all type of cerebral palsies can have seizure and mental retardation, the most severe being spastic quadriplegic, right? Okay, but one thing about MCQ for important MCQ for dyskinetic type of cerebral palsy is that it is associated with hearing loss. So there is also hearing loss. So there is sensory neural type of hearing loss, especially associated with the basal ganglia, because of also damage to the thalamus and vestibular nuclei present within the thalamus. So this damage to the vestibular nuclei within the thalamus ultimately is associated with hearing loss. So if the question comes, the history says that the child is suffering from cerebral palsy and he also has a hearing loss, think choreoathetoid type of cerebral palsy. And finally, ataxic type of cerebral palsy presents with ataxic gait, wide stand gait, and intention tremor. Once again, one thing to remember is that it is very easy of us to think that ataxic gait is associated with cerebellar injury, and which is in fact true, but most common site of injury in ataxic cerebral palsy would be forebrain, followed by cerebellum, right? Okay. Now finally, let's go towards the investigation of cerebral palsy. So understand that there is nothing much of investigation in the cerebral palsy, because the diagnosis of cerebral palsy is often clinical. From the clinical history and physical examination, the diagnosis of cerebral palsy is evident, but by doing some investigation you will have to at some point show that there is some kind of injury to the brain, and for that you will require imaging. Now, if the baby is small, let's say in early neonatal period or early infancy, you need to do an imaging. The best imaging of choice would be transcranial ultrasound, and not MRI, not CT scan. It is transcranial ultrasound because it is best to pick up intraventricular hemorrhage, intracerebral hemorrhage, and periventricular leukomalacia. So these things like hemorrhages, intraventricular hemorrhage, intracerebral hemorrhage, which is associated with prematurity or low birth weight, yeah, and it is associated with spastic diplegic type of cerebral palsy, is best diagnosed by transcranial USG. So if your child is in early infancy, the best investigation of choice or imaging investigation of choice is transcranial USG. Or if the child is in late infancy or early childhood, then the diagnostic investigation of choice is MRI and CT scan. Now okay, this is all about imaging. Besides that, let's talk about serially. What we will do investigation is you will take initially detailed history, and after you take detailed history you will do physical examination. Remember that there is involvement of cranial nerve, so there is involvement of eyes, so vision examination is important. Remember, choreoathetoid type of cerebral palsy is associated with hearing loss, so assessment of hearing is also important. Remember that cerebral palsy is also associated with dysarthria and hence slurring of the speech. So special examination or assessment of speech is also important. Remember, the most severe form of cerebral palsy are almost always associated with mental retardation, and hence examination of the intelligence or assessment for the mental retardation is also important. Remember once again that severe form of cerebral palsy are associated with refractory seizures, and hence EEG is important. And finally, to find out the pathogenesis or find out the pathological lesion within the brain, you need to do imaging. Once again, if the child is in early infancy, do transcranial ultrasound. The child is in the late infancy or childhood, do MRI, do CT scan. You can find periventricular leukemia, you can find mass, or you can find space occupying lesion, you can find hemorrhage, you can find infected cysts, and all those things, right? Okay, so this is all about the investigation of cerebral palsy. Now finally, let's talk about the treatment of cerebral palsy. Now treatment of cerebral palsy is it's quite difficult, because cerebral palsy, there is no any complete cerebral palsy is not a reversible disease. Once the damage is done, the damage is done. You can only have supportive management. So often the treatment of cerebral palsy is multidisciplinary. So multidisciplinary approach is that there is involvement of a pediatrician, there is involvement of the orthopedician, there is involvement of physiotherapist, as well as, because it has a lot of psychological and burden over those child who are not mentally retarded, they can also go into depression, and hence there is involvement of psychiatrist. Because of dysarthria, there is involvement of a speech therapist. Because of cranial nerve injuries like oculomotor nerve, there is involvement of ophthalmologist. Now this is the multidisciplinary approach. Now let's go specifically how to manage special type of cerebral palsy. So how do you manage spastic type of cerebral palsy? So the whole point of management of spastic type of cerebral palsy is elimination of this spasm. So generally you can try in the first line treatment can be antispasmodics. So systemic antispasmodics like baclofen, dantrolene sodium, and benzodiazepines, these are all muscle relaxant. They relax the muscles and they relieve spasm in some amount. But even if systemic drugs like baclofen, dantrolene, and benzodiazepine cannot resolve spasm, then you need to go local, and you need to give local injection of botulinum toxin within the adductor muscles, or any muscle which has underwent spasm, adductor muscles or muscles of the posterior compartment of the lower leg, right? Okay, so you can have local injection of botulinum toxin. Now remember, I told you that there is shortening or spasm of the Achilles tendon. Due to this shortening or spasm of Achilles tendon, there is equinus deformity and there is tiptoe walking, right? So to relieve this tiptoe walking, you need to lengthen the Achilles tendon. For this lengthening of Achilles tendon, you need to use bracing. So these are the bracing orthosis, foot orthosis. You need to understand that there is no heel in this orthosis at all. These are roughly maintained at abruptly 90 degrees, and so the child has to wear this orthosis for a long period of time. And what it does is that it applies stretch on the Achilles tendon and improves the laxity of Achilles tendon, and hence prevents the further shortening of the Achilles tendon. So if bracing does not work, you will have to do surgery. You will have to find the Achilles tendon, you will have to cut it and then lengthen it. So this is called Achilles tenotomy. So you are cutting the Achilles tendon and lengthening it. Now for adductor muscle spasm, what you can do is you can do adductor tenotomy. You can cut down the adductor and then you can lengthen the adductor muscles, and this will treat the scissoring gait of the spastic diaphasic type of cerebral palsy. So adductor tenotomy. Even if adductor tenotomy does not work, then you can do muscle transfer. You can take this muscle, you can take the adductor muscle and psoas muscle, and you can do a psoas muscle transfer inside at this place, and this will resolve the scissoring type of gait. Now sometimes even with management, even with the tenotomy and lengthening of the muscle, or even with muscle transfer, if it does not work, then you will have to find the nerve, you will have to find the lower motor neuron nerve, the second order neuron nerve, and you will have to transact that nerve so that the lower motor neuron, which was being persistently active and ultimately leading to the spasm of these muscles, gets damaged, and there will be no more further spasm. So you will have to do neurectomy. Now, for understanding which nerve do you want to transact, you need to understand the nerve supply of adductor compartment of the muscles. So adductor muscles are supplied by obturator nerve. So you will have to find the obturator nerve and you will have to do obturator neurectomy. So this single nerve neurectomy is can solve. It is like last resort procedure which can resolve scissoring gait. Now, sometimes even if adductor neurotomy does not solve the problem, you will have to go further closer to the spinal cord and you will have to cut down dorsal horn at the level of dorsal root ganglion of those nerves which supply the muscles which has underwent spasms. Now the question may arise, okay, cutting down ventral horn is justified because the motor nucleus come from the ventral horn and supply the muscle and the muscle which is under spasm. So cutting the ventral horn would explain the effect of this procedure, but here I am saying is we will have to cut down the dorsal nerve. So the rationale for this is that if you cut the dorsal root, then the afferent stimulus reaching the spinal cord is completely lost, and it was this afferent stimulus which was persistently activating the motor nuclei and ultimately causing a spasm. So if you cut the dorsal root, there will be no afferent stimulus and the motor nuclei will not get activated and there will be no spasm at all. And it is done, and the transaction of dorsal root is done preferably than ventral root, because if you approach the spinal cord from backside, from the posterior aspect, it is the dorsal horn or dorsal ganglion which is more easily accessible to you without causing much damage, because most of the surgery of the spine is done from dorsal part of the patient, right? And this process of cutting the dorsal root is called rhizotomy, and this procedure is especially called selected dorsal or dorsal selected rhizotomy, and it is a final procedure, the last resort procedure that is done to treat the adductor spasm, and it is done at the level of lumbar and sacral nerve roots, right? Because it is the lumbar and the sacral nerve root from which the obturator nerve arises. Okay, now this was all the treatment about specific treatment for spastic type of cerebral palsy. Now let's go to spastic quadriplegic type of cerebral palsy. In spastic quadriplegic type of cerebral palsy, often the child will be completely unable to walk because it's the most severe, and you will have to provide wheelchair support, right? Okay, now if the children has dyskinetic type of cerebral palsy like Parkinson's type of disease, the treatment is also Parkinson's type of treatment. You will try to stabilize the basal ganglia by providing dopamine. So you will try with levodopa. Often a response is not seen, but in some cases a response can be seen. So a trial of levodopa can be tried in dyskinetic type of cerebral palsy. Now finally, if you are done with the management of specific management for treatment of spasm or for the treatment of chorea, now let's go to the supportive management of this disease. Now we know that there is involvement of eye, so there will be eye care. There is also involvement of the hearing, so there will be hearing care. So because these children are mentally retarded, you will have to provide them with specialized education for mentally retarded. And because these patients have dysarthria, so difficulties speaking, so you will have to provide speech therapy. And finally, they also have dysphagia, difficulty swallowing. You will also have to give a proper nutritional support to these type of children. And finally, if they are not mentally retarded, then they are going to go into some kind of depression, and for those patients you want to have psychotherapy and counseling. So that is all about the cerebral palsy. Now finally, let's talk about the MCQs that I talked early in this video. Now attempt this MCQ. Which type of cerebral palsy is least associated with seizure and mental retardation? I told you the most safest form would be spastic diplegic. They are not associated with seizure or mental retardation. Now in second MCQ, status marmorata leads to which type of cerebral palsy? Spastic quadriplegic, dyskinetic, ataxic, or mixed? Now we remember status marmorata is marbled appearance of basal ganglia, and it occurred in term infant who underwent perinatal asphyxia. So in term infant who undergoes perinatal asphyxia or hypoxic ischemic encephalopathy, one site of damage is basal ganglia. Another site of damage is watershed area, and if this watershed area is damaged, then he will have spastic quadriplegic type of cerebral palsy, right? But another important site of damage is this basal ganglia, and which will give a typical marbled appearance, and this lesion is called status marmorata, and this damage of the basal ganglia will ultimately later on lead to chorioathetoid type of cerebral palsy. So hence the answer in this case, like status marmorata leads to which type of cerebral palsy? The status marmorata is a lesion of basal ganglia, and hence it will lead to chorioathetoid type of cerebral palsy. The answer is dyskinetic cerebral palsy. And finally, which of the following is not used for the treatment of cerebral palsy? One is levodopa. We know that levodopa is used in chorioathetoid type of cerebral palsy because levodopa stabilizes basal ganglia, and say chorioathetoid cerebral palsy will have Parkinson type of disease, so treatment will also be Parkinson type. Next, levodopa can be tried, so it can be used. Baclofen is a systemic acting muscle relaxant, so baclofen is used. Dantrolene sodium is also muscle relaxant, so it can be used. Magnesium, we have not heard magnesium till now, so magnesium I think cannot be used in treatment of cerebral palsy, so answer is magnesium. The question was, which of the following is not used for the treatment of cerebral palsy? The answer is magnesium sulfate. Magnesium sulfate is not used for the treatment of cerebral palsy. But wait, one thing that I have not told you till now is that we know that cerebral palsy, especially spastic diplegic type of cerebral palsy, which is the most common type of cerebral palsy, the most important risk factor is prematurity. So if a mother has to deliver a child prematurely in less than 37 weeks, then there is a greater risk of that child developing cerebral palsy. But studies have shown that if during this period, if before delivery, if the child is treated with steroid and if the child is treated with magnesium sulfate, this magnesium sulfate acts as a neuroprotective agent and hence can prevent development of cerebral palsy later in this life. So magnesium sulfate has neuroprotective ability, and hence magnesium sulfate is used for prevention of cerebral palsy. So please remember this fact, magnesium sulfate is used for prevention of cerebral palsy. But then again, in this question, the question is which of the following is not used for treatment of cerebral palsy? Magnesium sulfate cannot be used for treatment of cerebral palsy. It can only be used for prevention of cerebral palsy. And with this, our topic of cerebral palsy is finished. Thank you.